Hi, I'm Jim Hermiller from St. Vincent Hospital in Indianapolis. It's a really great pleasure to present this case or cases in what was going to be a sort of a complication section and Ask the Expert session. And the title of this talk is going to be Revenge of the Ross Procedure. So we're going to talk a little bit about transcatheter pulmonic valve replacement during this talk. And there's a bit of excitement at the end. So here are my disclosures. So what's the Ross procedure? So the Ross procedure is to essentially take the native pulmonic valve and place it in the aortic position. It was designed, particularly for young people. And in the pulmonic position, generally a homograft is put in place. There are many physicians, many cardiac surgeons that are able to do this in an effective way, but certainly it's a more complex than just standard aortic valve replacement. I really talk about two cases. One is a 47-year-old gentleman who underwent a previous Ross procedure back in 2006, and he got a 29 millimeter pulmonary homograft. This procedure was complicated by occlusion of his right coronary artery, VF. He had emergent vein graft bypass to his RCA. And he actually did well after 2006, up until about the last 6 months when he developed severe right heart failure and severe pulmonic regurgitation. Now this guy, I love this, he's a great guy, but he did appear to be from the Shire. It's 4'11", just a little thing. And he was about, at his current weight, he was 110 pounds with anasarca. So he probably had 25 pounds on him of salt and water. And had 4+ edema, his creatinine had bumped up, and he was quite sick. There he is right there. Now, this is just a great echocardiogram, all right? Here is the pulmonic homograft right here. This valve is just gone. It's flailing about here. You can see it flail down in diastole and flail up in systole. And there's really no difference in RV and PA pressures here. This is just a wide open valve. Here's his MRI. He's got severe PI, RV, RA enlargement. He fortunately hadn't blown out his tricuspid valve. Left system was normal. His right coronary and vein graft were included with a good collateral over there. And you can see his RV and pulmonary pressures were identical. His right atrial pressure was all the way up to 13. Surgical consult, nobody was terribly interested, as sick as he was, in doing any open heart surgery here. So the idea was, can we go ahead and do him with a transcatheter approach? Based on the CTA, he appeared to have a reasonable landing zone to get this done. The trick here is bilateral venous access as well as arterial access. The arterial access is to look at the coronaries during balloon occlusion to make sure there's no compression of the coronaries with a balloon up or the eventual valve up in the valve. Temporary pacemaker for pacing during deployment. And then you've got a pigtail catheter for angiography as well. You first start by positioning a Lunderquist in the left lower pulmonary vein deep, but without injuring the pulmonary vein. You pre-size and check for coronary compression. No pre-stenting was required here. It appeared, at least by CTA, it would be a 29, which it was. Here we've got a Lundy up into the pulmonary vein. There's a multi-track catheter that you can, it's a rapid exchange catheter that's next, really on top of the Lundy that helps you do the angiogram. Here's a sizing balloon. It's sized to about 26 millimeters. So we can see it's going to be, it'll be good for a 29 S3 and used an S3 here. This is with the balloon up, looking for coronary compression, and there was none. We've taken the valve up. Sometimes it's a little difficult to get the valve up into place, despite having that Lundy in there because of the turns. Can sometimes help to really pull the pusher back and reduce the stiffness of the whole system, and then get the valve up, which was done here. We have a nice little marker right up in here that helps us, at least in the AP projection, see where we're headed. So we get that up in place. And then going ahead and deploy during rapid pacing, and you can see we're right where we want to be. And this is after the valve is up. There's no PI. There's no gradient. Really, it's perfect. And you can see here the TE post deployment, nothing. Discharge day 2, lost another 10 pounds, echo no PI, no gradient. He, after all this, has done remarkably well, and he's back at work full time, and he's doing great. All right, this is the second one. This is a sort of an exciting one. 54-year-old gentleman. He's had 5 prior open heart surgeries. He had a Ross in 1996, complicated by multiple aortic pulmonary fistulas, and he's subsequently gotten an AVR with an Onyx valve. And his last surgery in 2018, his pulmonary valve was replaced again with a pulmonary homograft, a 28mm, secondary to endocarditis and clot. He had mediastinal exploration afterwards, and that gave him a 5th surgery. He's got recurrent disc exertion. He's got severe stenosis of the homograft, and this is his gradient across that thing. And he's got a 60mm gradient across the homograft. And it was thought that he had scarring of this thing, but you can see right here how it's pinched. This is, kind of some cool pictures. And you can see right here is this graft, a homograft, which is pinched and has this high gradient. Now, this was above the valve, so we thought, well, maybe we can just stent this thing. And if we stent it and we cause some disruption of the pulmonary valve, then we can potentially go on then and put a S3 in there. So pre-dilate with a 20 and 24 true balloon, stent just above the valve, and we'll decide about covered versus non-covered, and then a transcatheter pulmonic valve, not TAV, pulmonic valve, if necessary, although we're going to use a tab in that pulmonic position. All right, here we go. We're setting up, and you can see this. I think this is sort of scarred. You can see the aortic valve, mechanical aortic valve there. And these are just some pre-procedural sizing. We had a really outstanding proctor there, and tremendous experience, and so we're kind of going right along with all the suggestions. There was this little shadow here that nobody could kind of figure out exactly what that was, and that was pre us doing any dilatation or anything. So here we're lining things up. We do balloon dilatation. We're looking for coronary compression. There's no coronary compression. And after that, we notice, oh my gosh, there's all kinds of stuff going on here, right? There's this, looks like something's been disrupted, although we don't see leak into the chest or staining. And it also has sort of this kind of serrated appearance here. that almost looks a bit like a graft. So we put up a CP stent. This is a large CP stent. In position, this is a covered stent. It's got 2 balloons in it. It's really perfect for this kind of application, or a coarct. We're getting a little scared here. We're not sure what's going on, but you know, things are stable. So we blow that up. All right. We blow that up. Do an angiogram up here, and now we've got blood going everywhere. All right, now we've got blood. You can see this tracking up the mediastinum. There's disruption up here, and he's starting to get sick. You know, he's beginning to get hypotensive, although he's, you know, his systolic never got below 50 or 60, but clearly he's sick, and it's time for the surgeons to take over. All right, this is going to be another picture here. And you can see there's sort of blood tracking right here around this covered stent. And as I said, he starts to crash. Although, fortunately, he doesn't really lose his circulation. This is an angiogram from the aorta. And you can see whatever's been disrupted in the pulmonary is now pushing up against the aorta. All right. There's no way to fix that in any fashion. We're moving fast now. And my surgical partner, who's really amazing, Dave Hymanson, he and I are doing this case together. He'd done the last 2 operations, and put him on fem-fem bypass. And this is, he was cut down, stable as can be. And this is what happened. He actually had, between the last valve and the pulmonary arteries, he had this stent tube. And this is actually our stent inside of the tube graft that was surgically placed in. Basically, there's a big hole there. And it was probably kinking of that previous tube graft that we saw as the cause of the stenosis. But that basically just came unhinged from the pulmonary artery with probably initially with a predilatation. So what he's done is he's down in to the tube graft. This is the aorta. Tube graft here, cut down, and here's our covered stent that he's cut down through. So he basically pulled that all out, got it all taken care of, and he was extubated in 2 hours. He was walking the next day, normal renal function, home in 5 days, echo, normal RV, no gradient across the new valve. And I kind of look at this for this great guy, and he's doing very well now. This was lucky 6. Teamwork, in these, complex transcatheter therapies that are high risk, it is a team, and certainly in this case, it was a surgeon on top of the cardiologist, and Dave was able to put all the pieces back together. So thanks again for your attention. Dodged another bullet, you did.